purpose of this video is to provide you with the important information about the best surgical treatment for your condition. The reasons to consider lumbar microdiscectomy is generally pain. Most of the time the pain begins in the low back or buttock area and radiates down into the leg, particularly below the knee. A lot of times patients will have a component of back pain with this condition as well, and the back pain is not as likely to be relieved as the leg pain. The surgery really is best at relieving that part, although oftentimes the back pain gets better too. In addition to pain, some patients will have weakness or numbness, and those problems often also are improved, although generally not as quickly and also not as predictably. The leg pain relief is about 95% of patients get either complete or substantial improvement in their leg pain. Weakness is the second most reliably improved, and the numbness is the least predictable, meaning that the numbness, if you have any, may persist even indefinitely. Typically, a discectomy is considered after patients have had a trial of physical therapy and other non-operative type interventions. But for about 25% of patients who have this problem, the symptoms persist, and for a small portion, patients may have progressive weakness, which is another strong indication for surgical treatment. With regard to the surgery itself, a microdiscectomy is a minimally invasive type procedure, meaning that a small incision, usually an inch or so, depending on the patient and the level, but a small incision is made, and the dissection is carried down to the affected level. Usually it's L4 or L5, usually on just one side, left or right. And once the vertebra is exposed, a small amount of bone is removed, and a small amount of ligament, which covers over the nerve, is removed to create a window in order to see the nerve, and the nerve can then be moved over, and the disc material is usually coming from in front of the nerve. So the nerve is moved over, and then the disc is visible, or the disc herniation. I think it's important to understand that even though we call it a discectomy, it is actually a partial discectomy. We do not remove the entire disc, only the portion of the disc that's causing the nerve compression, essentially the part that's pushed out where it doesn't belong. But that fragment is removed. Any other sort of loose fragments are taken out of the disc space to relieve the pressure on the nerve. And that's really the purpose of the surgery, is to relieve the pressure on the nerve and give it a free and clear path. And relieving that pressure allows the nerve to become less irritable and less irritated and less painful. This does carry some risk. There's two types of risk, really. One is the risk of anesthesia, which has to do with your medical comorbidities, things like high blood pressure or diabetes, age, other medical conditions, and it may be that you would need to have an anesthesia clearance in order to have surgery. And there are also risks of the surgery itself. Again, anytime there's an incision, there can be an infection. It's possible that even though the surgery goes well and the disc is removed, that a person may have persistent pain. Again, it's more likely that they're going to have persistent pain in their back or hip area than the pain down the leg, which tends to be more caused from the nerve irritation directly. It's possible that a person might develop a recurrent disc herniation, meaning that the symptoms are improved and everything's fine for some period of time. Sometimes it's only a few weeks or months, sometimes it's years or decades, but essentially because the entire disc is not removed, another piece of the disc may essentially herniate or extend through that same hole, and cause the same symptoms. And that risk is somewhere between 4 and 7% for most patients. It's possible that the nerve could be injured from the surgery because, again, it has to be manipulated or moved. It could be stretched or harmed in some way, which could cause persistent pain or numbness or weakness in that particular nerve. Wouldn't really cause paralysis because it would only involve that particular nerve. The dura, which is the covering around the nerve root, could be harmed or torn or injured, which would require repair. Usually doesn't lead to a major issue, but those risks are all pretty small. The biggest risk is the recurrence risk, and again, that's 4 to 7%. The risk of infection, risk of nerve root injury, and so forth are much, much lower. Immediately following the surgery, patients often have excellent relief of their leg pain, although the back is usually sore and it's a little difficult to mobilize, but that incisional pain usually will improve fairly quickly. Often this type of surgery can be done as an outpatient, meaning you come in, you have surgery, you go home the same day. In order to go home, you have to be able to walk, you have to be able to drink, you have to be able to empty your bladder, you have to have adequate pain control, and of course not be having any sort of medical issues with your blood pressure or breathing, etc. Assuming that you're able to do those things, which most people can, then you can go home. Typically, I like to see patients back about 2 weeks after surgery. At that time, we usually get people started in some outpatient therapy with the idea that it will continue to a home program because, as I mentioned earlier, the involved disc is still an abnormal disc. We don't have a way to fix or repair or restore that disc to normalcy. And so how you treat your back, how you take care of your back will be very important in the long run. And so doing appropriate exercise like core strengthening, walking becomes very important and is really the best way to manage any residual back or hip pain. But it's likely that you will have some residual back or hip pain because the disc is still abnormal. There's not a way to correct that part of this problem. Typically after a lumbar microdiscectomy, patients do get very good relief of their leg pain, as I mentioned earlier. Often the back pain also is improved, and most patients can return to full function after a period of rehabilitation.